Hello, everyone, and thank you for having me at this year's International Community of Scholars in Kinesiology Student Research Week. My name is Dr. Nikki Harris, and I will be speaking with you today about how my exposure to the elements helped me build a research agenda aimed at identifying and rectifying disparities. Let's get started. For the past decade, research agendas have placed increased emphasis on how social and environmental factors have the potential to affect the health outcomes of individuals. Likewise, these social and environmental determinants can help shape the educational outcomes of students, even those in the health professions. I have a decade of experience as an athletic trainer in both clinical practice and education. My goal for today is to discuss how my own personal experiences working for diverse public institutions have helped me to establish a research agenda aimed at identifying important disparities existing between cultural and socioeconomic groups in both health and education. I hope that this talk can help empower listeners to consider future research on the development and implementation of equitable and inclusive practices which can promote achievement in marginalized populations. So now I'll tell you a little bit about my own academic journey. At 10 years old, I suffered from an autoimmune infection called rheumatic fever. This occurs secondary to an untreated strep throat infection. The disease results in inflammation of the body tissues such as the joints, and often the heart. In my case, the condition mildly affected my heart, but it did leave me with a more serious case of infection in my right hip, which required surgical debridement of the joint to clear the disease. As a result, I had a lengthy stay in the hospital, followed by a few months of outpatient physical therapy. I was lucky to encounter a pretty cool physical therapist, and it was then that I decided I wanted to be a physical therapist when I grew up. Out of high school, I decided to pursue my undergraduate degree in psychology on a pre-PT track at Wayne State University. Wayne State University is an urban institution in Detroit, Michigan. It is richly diverse with individuals from all over the world, particularly the Middle East and Asian nations. Learning from peers with a wide range of worldviews and perspectives helped to shape me as an individual, and I better appreciated, understood, and valued others that came from different backgrounds than myself. While I really enjoyed my experiences at Wayne State, I didn't quite grasp just how competitive physical therapy education programs could be. After failing to receive acceptance into a physical therapy program, I took a year off from school and I worked as a physical therapy aide in a local outpatient clinic. It was here that one of the physical therapists introduced me to the profession of athletic training. After going home and doing more research about athletic trainers and the athletic training profession, I decided that athletic training was essentially my dream job. The pursuit of my athletic training degree took me to Florida International University in Miami, Florida. FIU is an urban, Hispanic-serving institution with over 58,000 students, and it houses an incredible athletic training education program. Throughout my time here, I had the opportunity to learn didactically about injury prevention, clinical evaluation and diagnosis, therapeutic interventions, rehabilitation, and of course the importance of organization and administration as a healthcare provider. In addition, I was able to perform clinical rotations with a local orthopedic clinic, a local public high school, our men's soccer team, our women's basketball team, and of course football. Each of these clinical rotations provided me an opportunity to interact with patients of a diverse cultural variety. One of the most influential clinical experiences I had was one that I encountered with our women's basketball team. In 2010, the NCAA mandated that all student athletes be screened for the presence of sickle cell trait. This mandate took effect right before the start of winter sports. The athletes of our women's basketball team were screened by our team's primary care physician by blood tests, and then blood tests were sent off to the lab for testing. While we waited for the results, our women's basketball team packed their bags and they boarded a plane for a preseason game at the University of Denver. The head athletic trainer received the results to the tests while the student athletes were in the air. It just so happened that 3 of the athletes tested positive for carrying the sickle cell trait. One of the athletes in particular had an extremely high percentage of hemoglobin S. Individuals with higher percentages of hemoglobin S are at increased risk of vascular occlusion, which could lead to sudden death, particularly when they're in high altitude environments, such as Denver. For that reason, the plane literally turned around and headed back to Miami, and the game was canceled. Amazed at the severity of the situation, I wondered, how did student athletes with sickle cell trait who were not protected by this NCAA mandate, how are they going to be identified and how are they going to be properly managed during athletic activity? Especially in a city like Miami, where so many of the student athletes are of African or Afro-Caribbean descent. This is the largest population that is affected by sickle cell trait and sickle cell disease. This led me to my first ever research study, which sought to determine if secondary school, aka high school, athletic trainers possessed the knowledge to accurately diagnose exertional sickling and if they were using the recommended practices for the management of sickle cell crisis as recommended by our National Athletic Training Association consensus statement. The results of my study revealed that high school athletic trainers were familiar with the characteristics of sickle cell trait, and they were able to differentiate exertional sickling from that of heat illness. However, findings also suggested that athletic trainers were not knowledgeable on the management of sickle cell crisis. That's really important. We can know what sickle cell crisis looks like, but if we're unable to manage it, then we're still not reducing the risk of sudden death. Despite the release of a consensus statement by the National Athletic Trainers Association, we determined that high school athletic trainers weren't utilizing the resources that they had available to educate themselves on sickle cell trait in the athlete. So, growing from this research, I started to take a specific interest in the healthcare of ethnically diverse populations. After school, I landed my first job as the head athletic trainer for Miami Booker T. Washington Senior High School. This urban public Title I school was the first secondary school in South Florida to service African American students. Its demographics today are still reflective of this diversity. Over 97% of the school's students are classified as ethnic minorities, with a pretty even split between Hispanic students and African American or Afro-Caribbean students. While athletics at Booker T. Washington have established a stellar reputation over the years, academics at the school have not necessarily followed suit. The school is consistently ranked in the bottom 50% of schools in Florida, as dictated by the proficiency of students in math and reading. It is estimated that only 80% of students graduate from Booker T. Washington, which is lower than the state's average of 89%. Servicing one of the poorest areas in Miami-Dade County, approximately 89% of students in attendance at Booker T are eligible for free or reduced price lunch. Working in this environment, it didn't take me long to understand the effects of these factors on a student's health. When we look at the social determinants of health in this population, We have to consider how students suffer from things like inadequate housing conditions, and this might be because the buildings are old and run down, because they're infested with mold or pests, because they're overcrowded with family members or other individuals in their household. And we also need to consider that there is neighborhood violence literally at their doorstep. Often students and their parents relied on public transportation, as families often did not own a car or perhaps only had one car per household. Most parents lacked any form of higher education, and many Hispanic and Haitian students had parents who struggled with basic English literacy. Parents and guardians encountered economic instability regularly, some with no job at all, while others worked multiple jobs just to make ends meet, leaving their children often to fend for themselves at an early age. Many students were often visibly hungry. This community exists as a food desert, and even when food is available for purchase, students may not have the means to do so. Many children obtain their only healthy and sustainable foods from meals that were offered by the school. And this is just a fraction of the problems that these students in low socioeconomic communities have to navigate on top of successfully getting their education and participating in sport activity. While all illnesses and injuries are subject to the effects of social determinants of health, the comprehensive nature of concussion makes it particularly vulnerable and challenging to manage in these communities. In 2012, Florida adopted Concussion Bill HB 291, which mandated that athletes suspected of sustaining a concussion be removed from play immediately. They were not allowed to return back to their sport participation within the same day. When they do become symptom-free from their concussion, they can begin gradually returning to sport, first with light activity, then with moderate aerobic activity, followed by sport-specific drills, and then a full contact practice. All of these have to be supervised by an athletic trainer or another healthcare professional before the physician gives final approval for the student athlete to return to sport. At that time, concussion patients were traditionally advised to eat well and get plenty of physical and cognitive rest to help relieve any existing symptoms. Sounds simple, right? But what about my students? My students didn't have access to nutritious foods, especially if they were absent from school due to not feeling well. Heck, many of the times they actually lacked their own bed to sleep in or a quiet room in their house to rest. Then there was the transportation barrier. How would they get to a neurologist to be examined and obtain clearance to return to play? Many times their parents couldn't take off work in fear of losing their job or losing needed income, and they may not even have a way to get to the doctor if it wasn't within walking distance. Considering all of these factors, I started to contemplate on whether my athletes would have symptoms that last longer than their more affluent counterparts. Would they suffer from longer return to play times? These were the questions that sparked my second and third research inquiries. Results of these studies indicated that disparities did exist in baseline and post-concussion neurocognitive performance of adolescents with low socioeconomic status. Neurocognitive tests such as the impact test are commonly used to help manage concussion in athletes across the country. Furthermore, we found that concussion recovery time in high school athletes was influenced by an athlete's school's Title I status, their school's environment, whether it was designated as a medically underserved area or not, and their poverty level, as determined by their eligibility for free or reduced price lunch. On average, athletes with indicators associated with being on the lower end of the socioeconomic status scale had longer recovery times as measured by the total days lost due to their injury. Another thing I noticed in the secondary school setting was how much I was utilized as a resource for primary care. Student athletes from lower socioeconomic backgrounds lack economic stability, healthcare coverage, and transportation, and therefore they usually have limited to no access to quality healthcare. In many cases, interactions with their athletic trainer may be one of the only continuous encounters that they have with a healthcare provider. Seeing this in action made me understand that athletic trainers are positioned rightly to serve as the first point of contact regarding general medical concerns, and we create a vital bridge to the healthcare system for this vulnerable patient population. However, while within our scope of practice, some athletic trainers are more apt to provide these services based on the education and training that they have in primary care injuries and illnesses. This led me to pursue a small grant from the National Athletic Trainers Association Ethnic Diversity Advisory Committee, which seek to determine the frequency of primary care conditions that were encountered by Title I high school athletic trainers, as well as the athletic trainers' confidence when evaluating, treating, and referring this wide range of medical conditions. Results of this study indicated that athletic trainers working in low socioeconomic status schools were pretty comfortable evaluating and referring conditions, but they really lacked confidence in their treatment role. Furthermore, it went on to identify some common social determinants of health that affected students at low socioeconomic schools, as well as barriers and facilitators to the provision of primary care in the secondary school setting. For example, athletic trainers reported social determinants of health such as food insecurity, transportation, health insurance quality or lack thereof, violence in the community, and immigration status all significantly contributed to their patients' health-related quality of life, as well as to their accessibility and quality of healthcare received. Furthermore, common barriers that ATs encountered when referring patients for care outside of the athletic training facility included language barriers between the students / the parents and the athletic trainer or another healthcare provider, parental health literacy, and cultural competency in finding providers whose views match that of the patient. Likewise, strong themes were presented alluding to a lack of a trusted referral network and an inability of patients to receive timely and effective care that they needed in order to continue participating in their athletic activities. On a positive note, athletic trainers did believe that they may be utilized more as a source of primary care if education was provided regarding athletic trainers and their capabilities, and it was delivered to the community. Furthermore, athletic trainers felt that referral to specialty providers was easier when ATs were familiar with the resources that they had within their community, including things such as translation services, free medical clinics, and providers who accepted public health insurance, such as Medicaid. Lastly, athletic trainers felt that their evaluations and diagnoses of general medical conditions were taken more seriously in terms of the necessity for referral to another provider when they were backed by another healthcare provider, such as the school nurse. While working at Booker T, I decided to go back to school and obtain my terminal degree. In 2014, I enrolled in the Doctor of Athletic Training program at A.T. Still University. Shortly after, I was offered a job opportunity in the collegiate setting. In this role, I would serve in multiple capacities. First, I would be responsible for starting and expanding the Athletic Training Services program at FIU. This program was an athletic training clinic that was originally housed in Student Health Services. It would later move to the Recreation Center, and it would provide athletic training services to traditional students attending FIU. In addition to my in-clinic responsibilities, I would be responsible for providing care to campus recreation participants. particularly those from the men's and women's rugby team. I would also serve as a clinical preceptor for athletic training students, and I would teach in our Professional Masters of Science in Athletic Training program, the same one that I originally graduated from. As a teacher who was still a clinician, I gravitated to teaching our orthopedic assessment and our therapeutic intervention courses. I enjoyed teaching clinical evaluation and diagnosis as it was a constant refresher of the injuries and the body segments that were less seen in my clinical practice. Furthermore, it allowed me to bring my stories from the field into the classroom and give our students a real-world perspective. As a clinician, I enjoyed providing care to the general population. Not only because I had a constant opportunity to educate students about the athletic training profession, but also because the general population mimics so much of my previous low socioeconomic status patients in many ways. Because of the diversity of our institution, in our clinic, I encountered students from all over the world. Moreover, these traditional students were not covered under athletics. Many students were living on a tight college budget, they lacked transportation, and they often lacked access to healthy foods or activities. They also rarely had good health insurance because they were either kicked off of their parents' insurance for aging off or because they were international students. Because of this fact, we learned once again the importance of treating injuries in-house so that we didn't have to burden the student with obtaining specialty health care, especially if it failed to be absolutely necessary. This fact, combined with my position of teaching orthopedic assessment and therapeutic interventions, started to build the need for me to investigate evidence-based conservative treatments for some of our more commonly seen injuries. In the general population, two of the most commonly injured body segments are the knee, particularly those playing campus recreation sports on artificial turf, and the back, especially in the sedentary postgraduate student who spends a lot of time on the computer typing or doing research. This provided me with an opportunity to publish 2 clinical papers of interest. My first, Conservative Solutions for Patellofemoral Pain Syndrome, in 2018, and a second in 2021 on clinical evaluation of the sacroiliac joint pain. Both of these studies prompted the opportunity for the athletic training staff that I work with to determine best practices for evaluating and treating these conditions in-house, and it gave us information to help us change our practice to best benefit the patient overall and reduce their healthcare costs. outcomes and the needs of these individuals from these specific populations or geographic areas. Again, it is my hope that this research and the research of others in this area will inform individuals where these disparities lie, how bad their effects extend, and how we can all collaborate as a community to ensure that there are equitable and inclusive resources for all. Thank you for listening to me today. I am open to chat further about my experiences and my specific research at any time. I am also excited about any potential future research collaborations. Feel free to contact me by phone, by email, or easiest by Twitter. Have a great student research week.